Well, good evening, everyone, and welcome to the Brian Crombie Radio Hour on Saga 960. This past week, the federal government and the provinces got together and negotiated and announced a fairly comprehensive refinancing of the Canada Health Plan. And it's kind of confusing, and it's got a lot of things in it. And I think there's a lot of issues that a lot of us have in regards to emergency room wait, lack of access to family physicians, surgery wait, et cetera, et cetera. And so therefore, I thought it'd be really good to check in with an expert on this topic. Daniel Beland is a professor. He's a PhD, so he's Dr. Daniel Beland. I apologize. He's a director of the McGill Institute for the Study of Canada at McGill University, and he's also a professor in the Department of Political Science. He's the James McGill professor in the Department of Political Science at McGill University. Professor Beland, welcome to the show, sir.
Thanks for the invitation. I'm glad to be here with you today.
Thank you very much for joining us. So tell me, were you impressed or unimpressed with what happened with this negotiation? A lot of people said that the provinces were expecting a lot more than they got, but that it was good that they got what they got. What do you think?
Yes, well, the provinces, I think, maybe overestimated the leverage that they had during the pandemic when they started to ask the federal government to increase the size of the Canada Health Transfer, which is the biggest federal transfer and the one devoted to healthcare. They wanted Ottawa to increase the size of the Canada Health Transfer dramatically by $28 billion a year, right? So going from, wow, now it's $45 billion a year. They wanted Ottawa to basically increase the size of it by more than 50% right away. This is not what they got. So yes, there is a big gap between what they asked for and what they got from Ottawa. And actually, we talk about negotiations. In fact, yes, Justin Trudeau met with the premiers, but then he basically said, this is what you will get. And the premiers met again later, and they decided, yes, reluctantly, they accepted the new money. They don't have much of a choice anyway, because Ottawa has jurisdiction over the Canada Health Transfer, and they can decide what to do. They don't need to consult with the provinces. They could act unilaterally. This time, after months and months of wait, the premiers got a meeting with Justin Trudeau to talk about healthcare. But what they got is really modest compared to what they were asking for. For example, if you evaluate, we talk about $46 billion of new money over 10 years, $4.6 billion of extra money a year compared to $28 billion a year. That's a huge gap. Yeah. So the question is to know whether the provinces were just asking too much or and they adopted the wrong strategy in terms of bargaining, and they thought they had a lot of leverage, and in the end, they got crumbs compared to what they asked for, or whether Ottawa is just not doing enough. And so that in that sense, the premiers were right to ask for more money. And then the problem lies with the federal government. So it's up to you to judge that.
Well, you're the expert on this, and so I really appreciate some help. But I thought health was a provincial responsibility, and the money all comes from us, the taxpayers. So why is it that the provinces think they can get so much money from the federal government? Why does the federal government think they have to give so much money to the provincial governments? Why don't if the provincial governments have this need, just raise provincial income taxes?
Yes. So first of all, I think a little bit of historical background would be helpful here. And I think your question leads to that. So when the legislative framework for Medicare was adopted back in 1966, the federal government pledged to reimburse the province for 50 cents for each dollar they spend on healthcare in the context of Medicare, right? So at the beginning of the Medicare system as we know it, Ottawa did cover 50% of the approved cost. Now, this changed long time ago. In 1977, the federal government moved from a shared funding approach where Ottawa will reimburse 50 cents for every dollar spent by the provinces to a block grant approach where Ottawa will just give a certain amount of money every year, regardless of what the provinces are spending. And at the same time, they also transfer tax points to the provinces to give them more room to raise their own taxes to finance healthcare. That was, again, a long time ago in 1977. And the debate that we've seen in recent years, initiated by the provinces, is about how much Ottawa is actually spending right now, what percentage of the cost they are spending. The provinces said Ottawa currently is only covering 22% of the cost. So for every dollar spent by the provinces on Medicare, Ottawa only covers the equivalent of 22 cents. But then Ottawa said, no, in fact, if you include the tax points, the tax room that was transferred a long time ago to the provinces, when we altered the way the healthcare financing works in this country, the provinces actually are not that shortchanged, because currently Ottawa is covering 35, perhaps even 38% of the cost. So again, there is a debate about the numbers. Based on the work that I have done with Trevor Tong, who's an economist at the University of Calgary, we think that the federal government is right here, that if you include tax points, Ottawa is spending already more than 35%, or at least reimbursing at least more than 35% of provincial Medicare spending. So I think the provinces made a mistake here by basically lowballing what Ottawa is already doing. And then they said, well, if you add 28 billions a year, we will go to 35% of federal funding. But in fact, we're already above that. So that was, I think, a problematic framing on the part of the provinces and the territories. And the 13 premiers were on board with this big ask. It's the Council of the Federation, which excludes the Prime Minister and the federal government, was created in 2003 to increase the leverage of the provinces vis-a-vis the federal government. And this time, I think they failed in the sense that they were not able to get even close to what they were asking for.
The Council of the Federation excludes the federal government? That's kind of ironic, isn't it?
Yes, but it was an idea of Jean Charest a long time ago. And the idea was that, the provinces and the territories, the provinces can get together and increase their leverage vis-a-vis Ottawa. It's like the idea of a bloc, right? And that they can, collaborate among themselves as well in other areas. But this time, certainly, this approach has not been very fruitful in a context where Canadians are very worried, concerned about the quality of the care that they receive, labor shortages, waiting lists, problem in emergency rooms, and so forth. So what we've witnessed in recent months is really a political football, really this political fight over healthcare. And in the end, I think that the federal government won the political battle because they offered way less than what the provinces were asking for, way less. And they got away with it because the provinces in the end said, okay, we'll take the check. And of course, this doesn't solve the long-term problems. We'll have to maybe return soon and ask for more money. But it's like a national sport in Canada. Asking for more healthcare money is what provinces and territories do, right? And in the end, you're also right to say that it's Canadians who will pay, regardless of whether it's Ottawa or the provinces who are paying most of the bills, or we are in the end the ones who are paying for this.
And you're a political science, but you're also an expert on fiscal matters in our Canadian Federation. Wouldn't it make more sense for the entity that is spending the money and managing the process to be the entity that actually raises that tax revenue? Why have it go through the federal government to the provincial government? It just doesn't, like that indirect taxation, that indirect direction of funds just doesn't seem smart to me. I don't think a business would do it. A smart businessman would want the entity that's doing the work and responsible for the work and is going to be evaluated on whether that spending is efficient and effective, should be the entity that's raising the money. No?
Yes, there are some, actually, you're not the only one saying this. There are, policy experts and really commentators who have long been, they have long been saying, hey, let's transfer, dismantle the Canada Health transfer, and just we will have Ottawa will leave all this, the equivalent in terms of money of the tax room to the provinces. So that will be another transfer of tax points or tax room to the provinces. They will have more fiscal capacity, and then they will be able to finance healthcare themselves without the help of Ottawa. But there are some problems with that with that approach. And we have a paper with Trevor Tong that will appear in the journal Canadian Public Administration next month, and will be open access. And we discuss this policy alternative and other potential options to actually address the problem that you're mentioning and other challenges that face healthcare financing in Canada. I don't think that the system that we have now in the long run is sustainable. I think that we need to make more comprehensive reform. What we are just doing now in terms of the new money that Ottawa is adding to the table and the bilateral agreements between Ottawa and the provinces that will be signed hopefully over the next few weeks and months, this is just putting a Band-Aid on a broken foot or something. I think that we need more comprehensive changes moving forward. So the idea that you're talking about of really a transfer of tax points, massive transfer of tax points to the provinces, I think is one option. But then if you do that, you will probably have to compensate by beefing up equalization. Because, look, some provinces have a much higher fiscal capacity than others. So if you just tell the provinces, look, we give you tax room and you collect your own taxes and finance healthcare, what will happen is that provinces like New Brunswick or Manitoba will fare, they won't fare that well compared to, say, Alberta, right? Because some provinces are richer, they have a greater capacity to raise fiscal revenues, although they might decide not to raise that money. For example, we know Alberta doesn't have a provincial sales tax. It's the only province in the country that doesn't have one. They could create one, but they don't want to. Politically, it's toxic there to even mention this possibility. So another problem here with your potential solution of transferring tax space to the provinces and telling them, hey, you can do what you want, is that some provinces may decide not to occupy all this new tax space. And then it's, I think, the residents of that province that will suffer.
Well, isn't that actually part of the
solution?
Isn't that part of the problem? In fact, didn't Jean Charest do exactly that? That he asked for that tax room, was granted that tax room at one point in time, and didn't use all of it to spend money, use some of it for a tax cut.
Yes, that was about the specific instance with Jean Charest was actually about equalization. So, he asked for more equalization money. The formula was changed. Quebec got more money, and then he enacted a tax cut, right? But yes, you could say the same thing about tax points, that provinces may not, they may decide not to actually,
but Professor,
use that space.
But Professor, if health is truly a provincial responsibility, and the provinces, in their own judgment, based on their elected government, decides to either have a tax cut in the case of Jean Charest, or doesn't have a sales tax in the case of Quebec, or may not have that fiscal ability to spend like other places. And your example, Nova Scotia, New Brunswick, or Manitoba, isn't that right? If what you're saying is that there's equalization grants hidden in the health transfers. And if equalization is a good thing that we decide on, why don't we have a specific judgment on equalization rather than it hidden in the Canada Health Act?
Well, it's not hidden. So what happened before the Harper years, there was actually equalization, formal equalization within the Canada Health Transfer. And then under Harper, this was changed, and now the provinces receive the Canada Health Transfer on a per capita basis. So it just depends the number of residents you have in your province. That's it, right? But there is still redistribution, because if I give $1 to Alberta and $1 to New Brunswick, okay, they receive the same amount of money, but proportionally, Alberta contributes more than New Brunswick to the federal treasury because it's a richer province and people pay more taxes there, right? On average. So there is always redistribution, even if you allocate the money on a per capita basis. So that's a bit technical, right? But there is redistribution. But equalization, which is a separate program for the Canada Health Transfer, it's pure redistribution. Some provinces receive equalization and others don't. And the provinces can do what they want with equalization. There are no strings attached, right? In opposition to the Canada Health Transfer, where the provinces, at least, they have followed abide by the five broad principles that are embedded in the Canada Health Act of 1984. And so what we have here is, I think, a complementarity between the Canada Health Transfer and equalization. But what we have seen recently is that the Canada Health Transfer is becoming bigger and bigger, and that's not the case of equalization. And that's not necessarily a problem, because actually inequalities among provinces declined in recent years, in part because of the oil bust and the economic downturn in Alberta. But now things are doing much better there, and so these inequalities might rise again. So there are a lot of factors that we have to take into account here. Fiscal federalism is a pretty complex issue, and I think that what we've heard in recent weeks and months, the back and forth between Ottawa and the provinces and territories was quite simplistic. But when you look at the numbers and you look at the history of the system, there is no easy solution, and each solution will require some adjustments to other parts of our fiscal system and other parts of federalism, right? And I'm not sure that there is appetite right now to totally redesign our federal system, our fiscal federalism system. And certainly what we've seen recently, the framework that Justin Trudeau announced and the provinces reluctantly agreed upon, that this is, again, just a relatively minor change, considering, I think, the problems that we are facing, not just in the short run, but in the long run.
Well, and I guess my argument comes down to, do you think that every Canadian deserves comparable healthcare wherever they live across the country? Or no, you get better healthcare if you live in a richer province than in a poorer province. And I guess I understand your point that sending it out on a certain amount of dollars on a per capita basis makes a lot more sense if you believe that you should have an equal access to quality, equal healthcare across the country. We're going to take a break for some messages and come back in just 2 minutes with Professor Beland. I'm going to ask him about this extra 25 billion, sorry, my mistake, 25 billion, not million, 10-year plan that's a special, separate program to tackle specific issues. And I'm going to ask him about some of the problems that we've got in our healthcare system, including emergency room waits, etc. Stay with us, everyone. We'll be back in 2 minutes. Welcome back, everyone, to the Brian Crombie Radio Hour on Saga 960. My guest tonight is Professor Daniel Beland. He is a professor of political science at McGill University. He's a specialist in fiscal federalism. I think it's interesting that this Canada Health Act that was renegotiated last week is really probably one of the biggest examples, other than equalization, maybe, in our fiscal federalism system. And so therefore, very interesting to chat with Professor Beland. Professor, there's this 25, I Freudian slip said million, because I guess that's what I hoped it would be, but 25 billion extra fund over 10 years to tackle top healthcare priorities, including primary care, access, and shoring up fragile healthcare workforce. Given the numbers that you're talking about, 25 billion over 10 years actually sounds like a pittance. What do you think? Is that helpful?
I mean, it's helpful because it's new money. So the provinces are wanted new money. They didn't get as much as they asked for, but that's a significant amount of money. But what's interesting here is that out of the $46 billion of new money, most of it will be allocated through bilateral agreements. And so these bilateral agreements will be signed between Ottawa and the provinces and territories. We saw something similar happening back in 2017, where we had bilateral agreements on community care and mental health. And at the time, that was for $11 billion of extra money. So this is bigger. More money over 10 years. But it's still relatively minor, considering the sheer size of the Canada Health Transfer, which is currently $45 billion. So now if we talk about on average $2.5 billion a year extra, this is less than a 5% increase if you just take that part of the deal. So $25 billion over 10 years, but Ottawa is currently negotiating with the premiers, with each of the premier, to have bilateral agreements to agree exactly on how this money will be spent. But yes, they are talking about shared priorities, 4 areas: family health services, health workers and backlogs, mental health and substance use, and the modernization of the healthcare system. So each agreement will be different. So that's the idea here, that we should not have a one-size-fits-all approach for all the provinces and territories. Their needs are different, right? So we should have a targeted agreement for each jurisdiction. And so there is something that makes sense here. At the same time, you can also say this is a bit of a divide and conquest approach on the part of Ottawa to say, well, we'll just deal with you separately, right, for the negotiation rather than as a block, which is probably easier to manage. That's what they did back in 2017. So
that's what they did with daycare as well,
yes.
Did they not?
Sorry?
Isn't that what they did with daycare as well?
Yes, exactly. This is exactly the same template that they also used more recently in the daycare file. So it's a proven method. I think the Trudeau government likes this approach, and the provinces don't have much of a choice if they want more money to follow that script, right? Which they did back in 2017 for mental health and community care, and which they did more recently over child care. Now, where are we going with this? The window is pretty narrow. The time frame is pretty narrow here because the federal budget should be tabled in March or maybe early April. And normally you will want most of these agreements to have been signed, or at least to have been, sketched by the time the budget is presented. In the budget, you will have the new money that we just discussed overall, but it's not sure that all the agreements will be signed by the time the budget is actually tabled, which is not a problem per se. But I think that the provinces want the money as soon as possible. The same thing for the territories. So I think they have a strong incentive to move fast and try to negotiate these agreements quite rapidly. Back in 2017, it wasn't the case. It took a long time, for example, for Manitoba to actually sign an agreement with the federal government. I think it took more than a year. It would be surprising if we'll see that this year, because the healthcare needs are so strong post-pandemic right now in Canada that it would be really bad form for the premiers and also the federal government to delay the signature of these agreements for months and months and months, because Canadians want action now.
I think there's some specific issues that were identified both by healthcare commentators and professionals and analysts, and are part and parcel of some of this emergency money and other money. And I wonder if you've got some comments on them. Two we've talked about already, which would be access to primary care physicians, and the second would be wait times in emergency rooms. Do you think that anything that we're doing right now is going to address those two issues? We've got lots of stories of people that are being treated in hallways in emergency rooms, and from what I understand, the biggest challenge with emergency rooms is that beds in emergency rooms are being used up by people that have already been admitted to the hospital, but there's no room in the hospital for them to move, and the lack of room in the hospital is either a problem of there's not enough rooms in the hospital, or there's rooms in the hospital, beds in the hospital being taken up by people that should be moved out into long-term care or back to home health care. And so it seems like it's either a problem of aged people not being moved into home health care or out into long-term care that are using up hospital beds, that are crowding out the hospital beds such that there's not a room for emergency bed people to move there. And so therefore there's not enough emergency room. And the problem is you go to emergency room, which I did twice in the last little while, and you wait 6 to 8 hours.
Yes, this is not a new problem in Canada, but things are quite bad right now in some provinces at least. If we talk about emergency rooms, I think we know what the potential solutions are. But it's not just about throwing money at the problem that will solve it. We need to rethink the ways we are going about our business here. So first of all, of course, a lot of people who go to emergency rooms should not go to emergency rooms. They should go to a clinic, right? But of course, it varies from province to province, what's available and so forth. But we should make this availability of clinics more extensive and have the communication so that people really know where to go. For example, online, they could just go online, know exactly what the waiting time is, where, right? I think we should perfect that approach and empower patients, empower people, and tell them, okay, here, if you go to this hospital, you will wait 6 hours. But if you go to that clinic, depending on what, of course, your illness is and what you have, then you will wait only for, an hour or an hour and a half, right? So I think that we need better communications. We need better coordination within each of the provincial healthcare systems. We also need, I think, better, the better use of new technologies within the healthcare system. People joke here in Quebec, during the pandemic, where they were still sending some files through fax machines. Like, who's using fax machines today, right? Who's
Doctors and pharmacies are.
Yes, some pharmacies are, because it's the healthcare system that's using them still. I think there is, we have a lot of work to do, but I don't think that it's just about money, right? And sometimes there is resistance against them, telling people, maybe you should not go to the hospital for this. Maybe you should go to a clinic or elsewhere. And at some point we will need to be quite assertive about this, because the system will just drift out of control.
Okay, so let's talk about primary care or health or access to a family physician, because you're suggesting that's one of the problems that's causing people to go to emergency room, and I agree. I heard a statistic that 5% in 2019, 5% of all family physicians left to go to the United States, and so I think that and also that family physicians are paid at minimum a half of what a specialist would pay, and so therefore family physicians are paid. They're paid well relative to the rest of Canadians, but poorly relative to specialists. And a lot of them are self-selecting to either not become a family physician to start with because of that, or if they become a family physician, to leave and move to the United States where they get paid more adequately. And so pay seems to be a problem. It also seems that we're not educated enough, maybe not allowing enough into our medical schools and our medical system. So we've got a quota system, it would appear, that tries to restrict supply of medically trained physicians, such that I guess we keep prices up in basic supply and demand. We also have a lot of foreign trained medical workers that aren't being approved. And then I think we've got technology that we're not using to the extent. A lot of people got used to actually having a visit with a physician over Zoom during the pandemic, and they kind of preferred that rather than waiting for 2 hours in a doctor's office. So what's the solution with primary care family doctors?
Once again, there's no silver bullet. I think it's a combination of different tools. You're right about technology, about the use of Zoom and other communication technologies. I think we should not just revert to what we were doing before the pandemic altogether. Especially when people live in remote areas or small town, right? If you live downtown Toronto, it's not that hard maybe to go to see your doctor. But if you live in a small town, or you live on reserve, or you live in, far away from a big city or from a hospital, these technologies are especially important. In terms of access to a family doctor per se, I do think that training is important. It's expensive to train physicians. It's very expensive, but the provinces have to really invest more in this. They have to just train more doctors, train more physicians. And of course, in terms of foreign credentials, we have been talking about this for so long.
For so long.
Some progress has been made, but there are still a lot of people who are, who could easily practice here with some form of retraining and so forth, and they can't do it. And we need them really badly. These people are already in Canada. They are already trained. So why are we waiting all of this human capital, these human resources, just for often technicalities? So yes, these are important tools. Now, as for the United States, physicians moving there, it's the case that the United States, in many sectors, there are just more opportunities. It's a much bigger country than Canada. The job market is bigger. And in terms of healthcare, they have a lot of private hospitals, and that can pay really well. But the US spend even much more than Canada on healthcare than we do. So they also waste a lot of money, right? I'm not sure we can really compete against the US in terms of salaries. But I think if we train more physicians, if we also have more physicians, foreign trained physicians who are already in Canada, enter the system and work here, I think that we'll move in the right direction. Now we can try also to fill the gap between, I make sure that family physicians are well paid. It's already pretty, there's pretty good conditions, but yes, specialists earn much more, and that creates a disincentive for some people, some young physicians, to take that path. You can make way more money as a specialist, so why becoming a family doctor? At the same time, there are advantages to be family doctor. You get to know your patient better. You can have a more steady schedule, and if you're a specialist, you're always in the emergency room or in doing surgeries and the weekend and so forth. So I think that there are different life choices that matter here too. But certainly, supply is very important, and we need to improve the supply and increase the supply of physicians in our system, urgently so.
One of the other issues that was identified was mental health, particularly mental health for young people. And I saw the statistic that mental health issues, particularly during and after COVID, if you can say we're after COVID, because I guess we're still in it, but COVID impacted mental health issues for young people fairly dramatically. And that to wait for a mental health care practitioner for a teenager was 3 times as long as for an adult. Is there something that we need to be doing far better with mental health, particularly for kids?
Absolutely. I teach at McGill. I have hundreds of students a year and a few hundred students a year. And I've seen just anecdotal evidence, but also for the conversations I've had with students or basically being absent for a reason or another, telling me that they face a lot of challenges in terms of mental health. I think younger people and people in general are more open about this than they used to be, which is good. But then we need to be able to help them. And I think that more money is coming, and that's an issue in terms of the bilateral agreements that we are talking about between Ottawa and the provinces that are being negotiated right now. Mental health is mentioned as one of the 4 priorities stated by the federal government. At the same time, this is not enough, and so we need to do more. And I think that in that case, Ottawa will probably still need to engage with the provinces about this, about perhaps adding more money to this later on. What was just announced earlier this month is just the beginning of a process, right? And I think that mental health, especially mental health for younger people, should be a major priority. The same thing for long-term care. You mentioned long-term care earlier, and I want to say again, we should not forget what happened during the pandemic. We should not forget how many people died who could have lived for many more years. We should not forget how they died and how their relatives, their children, their grandchildren suffered, seeing them suffering and dying like this. And I think that we are forgetting this maybe too fast. And politically, there was a strong momentum to really dramatically increase federal funding for long-term care during the pandemic. But now, it seems that we are a bit stalled. It's stalled. And I think that we should have a conversation about long-term care. And if the premiers want to go back to the federal government to get more money, I think the focus should be on long-term care and on mental health. And I think Canadians can understand the importance of these 2 areas, and then it's probably possible to do more about this moving forward.
We're going to take a break for some messages, but I'm going to come back and ask the professor when we come back, what's going to happen in the future? Because everything that we've been talking about for the last couple of minutes is only going to get worse as the baby boom ages and more people are in that age group where they're demanding more and more long-term care and healthcare resources. And so this system that we don't know if it's sustainable now is only going to become far less sustainable in the years to come. Stay with us. We'll be back in 2 minutes with Professor Beland. Welcome back, everyone, to the Brian Crombie Radio Hour on Saga 960. My guest tonight is Professor Daniel Beland. He is a political science professor at the University of McGill University in Montreal. He is an expert on fiscal federalism. He is a very smart guy. I've had the privilege of interviewing him a few times before, and I've always been impressed with his knowledge of the topics. Professor, we talked about some of the solutions. You sort of suggested it was, the provinces had to take what the federal government was offering. You didn't use these words, but I sort of read that you're saying we're kicking the can down the road. We're going to have to deal with it in the future. I interviewed someone in the long-term care area, and they said that there's a coming tsunami in expenses for long-term care because the baby boom is aging and our demand for long-term care is going to increase dramatically as the baby boomer gets into their years of 70s and 80s, and that there's no way that we can house them in institutions, though we will need to dramatically increase our institutions, but that we're also going to have to dramatically change our attitudes to and funding of home care. And then I interviewed a healthcare provider, and he was saying, or a healthcare policy expert, and he was saying that something like 80% of your healthcare dollars, your lifetime healthcare dollars, are spent in the last 18 months of life, and that given again that the baby boom is going to be this big bulge of people that are going to be entering into those years that are going to become closer to their leaving, we're going to incur a lot of healthcare dollars, like a lot of healthcare dollars being spent. So if we got this problem with long-term care, and we have this problem of just, healthcare with the aging baby boom, and you're saying that it's not sustainable now, how can it be possibly sustainable in the future? What are we going to do if we've got this coming tsunami of the biggest age bulge just coming now into their senior years?
Well, we have to be careful here just about talking about tsunami and so forth. I mean, if you look at healthcare spending, population aging right now is not the main factor behind this, right? There are other factors, like in terms of wages for healthcare workers and also the price of medical drugs. We haven't talked about pharmacare yet, but it's also an important concern moving forward and something that's being discussed in the context of the supply and the supply and confidence agreement between the NDP and the Liberals, because the NDP wants more action on pharmacare. But look, yes, there are major challenges. In a paper that I wrote with Trevor Tom from the University of Calgary, which is available online at the School of Public Policy at the University of Calgary. If people Google my name and University of Calgary, they would probably find it. And then you can see that one of the things we propose to fix the long-term fiscal challenges of healthcare in this country is actually to create a specific add-on to the Canada Health Transfer to compensate the provinces for the added costs created by demographic aging. Because we have to understand something here. There are some provinces that are older than others in terms of the average age and so forth, or the percentage of people who are age 65 or 75 or 85 and older. And it will be especially tough for Atlantic provinces, right? Because you know what's happening traditionally in Atlantic provinces, working age people will move outside the province to work, and then they return there to retire. And, they are facing a major demographic challenge, which is not the same level of challenge that you find in younger provinces like Alberta, for example, which has attracted a lot of younger people, a lot of younger workers to the province, and also, frankly, provinces that attract more immigrants, right? So I think that we need to address this demographic aging, especially in the area of long-term care, that the federal government could do more in that regard, but we have to do it in a way that will also be mindful of the fact that some provinces are facing an even greater challenge than others regarding population aging, because they are aging more rapidly than other jurisdictions. As for long-term care per se, I do agree that we should, and many people are saying this, I'm not the only one, nothing what I've said today is really original, right? We have been talking about this for a long time. There's a lot of literature about this, scholars, newspaper articles, books written about this. Home care is really a major part of the solution. It won't solve all the problems. There are older people who need institutional care. They cannot stay at home. But most older people who are frail or sick, they prefer to stay at home as long as possible. And if we create the proper infrastructure for home care, not only these people will be happier than in institutional care, but we will also save money, because it costs a lot of money to institutionalize people, right? More money than to help them stay at home, having people bringing them food and having a nurse visiting from time to time and so forth. So I think that we know that home care is part of the solution, but I don't think we have done enough in Canada compared to other countries to really make major progress, the progress that is really needed and needed now, as our population is aging quite rapidly in the context of this, mass retirement of baby boomers that we are witnessing in front of our eyes.
Professor, I really appreciate your comments. And you're obviously an expert in so many of these areas. But I got to tell you, it's bothersome that so often you say, this is not the first time we're talking about it. We've been talking about it for a long time. There's lots of papers written about it. There's lots of proposals. It seems like all we do is analyze and propose, and we don't do anything about actually solving the problem.
Canadians are worried about healthcare. It's the case from coast to coast to coast. Politicians, I think, are also worried about their own political future, and they want to avoid, to take any risks regarding this. And for example, the premiers, they prefer to go and blame, the federal government and say, well, we need more money. And then the federal government will just say, well, it's the provinces, it's their job to fix the problems, and they don't do this and that and that. So in our federal system, it's easier to blame other people at a different level of government for the problems that we are facing. And I think that's an accountability issue. And that may actually be detrimental to solving our healthcare problems. But in the end, I think that the pressure is on, the public pressure is on, and politicians, instead of blaming each other, should try to work together across levels of government to actually address these problems. I think we saw some progress with what was announced by Justin Trudeau recently, and the fact that the provinces are willing to accept the money, even if it's far from what they had asked for. But I think they need to be more engagement and more dialogue about this. And I would say also that the provinces should experiment, right? There is, in the US, they use this expression, I think it's a American politician who used that term, that the states were laboratories of democracy. Well, in a way, the provinces are laboratories of Medicare here in Canada. And we have also to increase the data sharing and how we learn from the best practices and what is done in other provinces, but also in other countries, in terms of solving our problems, like access to family physician, like, waiting lists in emergency rooms or for elective surgeries and so forth. So I think that, we need to get serious about this, but politicians will only act and take risks if there is strong public pressure on them to innovate and try something that might be risky for them politically, but that in the end might help people and help improve our healthcare system in the long run.
Professor, you said that there were 5 principles in the Canadian Health Act. Any idea what they are, and are we actually achieving them?
Yes. So just for the context of the Canada Health Act, the Canada Health Act was enacted in 1984, and it was really, the idea was to really basically force the provinces to deliver the good. After Ottawa had really, revised the funding system back in 1977, and there was a sense that the provinces were not really following the rules that had been agreed upon earlier on. And so when we talk about the Canada Health Act, it has broad principles in terms of the way the federal government, the provinces should manage healthcare. For example, universality is one of the main aspect of the Canada Health Act. So the provinces should cover all the residents in their province, right? The second principle, so the first principle, as I said, it's universality. Then comprehensiveness, so that the coverage should cover what is medically necessary. So the idea of medical necessity, so that provinces should offer comprehensive healthcare coverage to their residents. Then accessibility is a major principle, the third principle of the Canada Health Act. So accessibility is about providing so-called reasonable access to doctor services and to hospitals. And we can see right now that this principle in, across the country is being violated in a way.
We're not
right?
meeting it in emergency rooms. We're not meeting it in long-term care. We're not meeting it in mental health. And we're not meeting it in Indigenous populations.
It's a very important issue also that we have not talked about today, but that is absolutely crucial. Then a fourth principle is portability. So that's not a big issue. It's when you move to a different province or territory, you should be able to receive coverage in your new territory or province of residence. So that's not as big of an issue. And then there is the idea of public administration. You know, that that Medicare should be administered by the state, by the government. But certainly, when we talk about some of these principles, and certainly when we talk about comprehensiveness and especially accessibility, there are some obvious flaws within our system. But we know that the federal government has been really reluctant to actually apply the Canada Health Act, because if the provinces violated at least one of these principles, these 5 principles of the Canada Health Act, Ottawa can actually cut some of the funding that they are allowed to receive under the Canada Health Act. But the federal government is really reluctant to do this because of the potential political backlash they could face. Again, we go back to this idea of political risk, of electoral risk that politicians face. Politicians in the provinces and territories face these risks from their constituents, but the federal government, the prime minister especially, they also face these risks when they are afraid that the provinces could go after them, especially if they will cut funding because of them violating one of the principles of the Canada Health Act. These are very broad principles too. So, you know, it's a bit tricky to actually apply this Canada Health Act. And we know that the provinces are very reluctant to accept any form of strings attached, any form of conditionality when we talk about healthcare. And this time around, what was announced earlier this month by the federal government is basically a form of quid pro quo. We give you more money, but certainly not as much as you wanted to. But in exchange, we don't ask that much in exchange. We don't go with hard conditions like, okay, so we'll agree on some, shared goals and maybe data sharing and so forth, but the strict minimum. And that's a low risk approach that the federal government took. And that's low risk approach in the long run can be costly from a policy standpoint, because we need to do more to address the challenges. And so I think here it's not to say, oh, we should blame Ottawa, we should blame the provinces or the territories. I think that, the system is so complex that the blame should be shared by all these different political actors. It's not just one level of government that's guilty here of inaction or not acting promptly enough and not boldly enough. I think it's a shared responsibility that all our politicians have.
I think you're probably right. You're undoubtedly right. But the problem with that is then nothing gets done. And we've somehow got to be able to figure out what is the catalyst or the gatekeeper or the stopgap or whatever it is, the right word, that is stopping action from taking place. And I really worry that accessibility is a big issue today, but I think comprehensive is also something that we haven't achieved as people get billed for a whole bunch of extra things, and pharmacare isn't included as of yet. And the healthcare dollar spent on pharmaceutical products increases from like 15% to 50%, and we don't fund it unless you've got a good employer plan. Anyway, we're going to take a final break and come back with some concluding comments where I'm really going to put it to the professor about, does our federalism actually work? Stay with us, everybody. Welcome back, everyone, to the Brian Crombie Radio Hour on Saga 960. My guest tonight is Professor Daniel Beland. He is a professor of political science at McGill University in Montreal. He's an expert on fiscal federalism. We've been talking about the healthcare accord between Canada, the Federation, the federal government, and the provinces, where we've committed a substantial amount of extra money over time. Not enough, according to the provinces, and maybe not comprehensive enough to solve the problems. I got to ask you a question, Professor Beland, as we finish up here. The report on the Emergency Measures Act came out last week, and I know that's not the topic that we're talking about. But one of the things that came out of that I found really interesting is the inquiry council in his report found that the federalism wasn't working. That politicians provincially and federally wanted to blame each other rather than working together, and that sounds pretty consistent with some of the things that you've been saying in regards to healthcare. So I got to ask you, is our federalism working today?
Well, I think that there are some major problems, and you mentioned only two issues here. If we talk also about natural resources, about reconciliation with Indigenous peoples and so forth, I think that there are a lot of areas where our federalism is broken, or at least is facing major challenges. And I think that Canadians should ask, politicians to step up here and not accept the idea that it's only, one side that is wrong. So it's either the provinces or Ottawa. It's a problem in terms of coordination, and we should pressure people at both major levels of government to actually deliver and work together instead of having these, screaming matches, which in the end leave us wanting for more. And in the case of healthcare, it's also leaving patients and families in need. So it's not right. And I think that we need to exert all the pressure we can on politicians to deliver and to work together rather than just playing a blame game that in the end benefits them, but not us.
Collaboration, work together, communicate. Sounds like interesting concepts. Professor Beland, thank you so much for joining us and telling us a little bit about the Canada Health Act and about the accord from last week. I really appreciate it, sir.
You're most welcome. Take care.
That's our show for tonight, everybody. Thanks for joining us. I remind you, I'm on every Monday through Friday at 6 o'clock in the evening on 960 AM. You can stream me online, even from Montreal, at www.saga960am.ca. All my podcasts and videocasts are available on briancrombie.com. Good night, everybody. Thank you, Professor.
Take care.